Greetings from Jipmer, Pondicherry. I am really grateful, honored, and privileged to be a part of AOA 2021. Thank you very much to make me a part of AOA 21 and give me this opportunity to discuss about my topic, which is morbid obesity in a parturient. So coming to the basics of morbid obesity, WHO has stratified obesity into various categories, and morbid obesity falls in class 3 category of WHO stratification. Parturients who have a body mass index between 40 to 49.9 are termed as morbid obesity. What is different and what are the risks involved in such category of parturients? All of us would be aware that comorbidities, when compared to non-obese, occur more frequently in patients who are obese. The most commonest type of comorbidity which is observed is diabetes type 2. Even the obstetric complications differ between obese and non-obese parturients, and the commonest obstetric complications which are encountered with obesity is obstructive sleep apnea and venous thromboembolism. There are fetal complications which also show increased frequency when a parturient is obese. Now, what happens? What are the issues related to the respiratory system? Let me concise it into a simple animation. Obesity with an enlarging uterus would push the diaphragm up into the thoracic cavity. Therefore, the lung volumes tend to be compromised. But to counteract this, there is a widening of enteroposterior and transverse diameter because the rib cage is shifted outwards and the subcostal angle is widened by 50%. The other ways of compensating these physiological changes is that the patient has increased respiratory drive. But despite of increased respiratory drive, these parturients who fall into the category of morbidly obese have airway edema. There is more fragility of the mucosa, and therefore they get to have higher incidence of obstructive sleep apnea. However, with increased respiratory drive, the tidal volumes are increased despite a fall in function residual capacity. So there is a minimum change in total lung capacity. The diaphragm is pushed up. Nevertheless, the excursions of the diaphragm remain normal, and there is increased oxygen production as well as increased carbon dioxide production. What are the normal parameters which we see in obese pregnant patients? On top of the increased pre-pregnancy values, there is 20 to 30% increase in oxygen consumption, 30 to 50% increase in blood volume, and almost 50% increase in cardiac output. But in morbidly obese patients, there is something in addition which we must look out for, and that is existence of pulmonary artery hypertension, which is exacerbated by obstructive sleep apnea. This occurs because there is increased pulmonary blood flow. If the parturients have pre-existing pulmonary artery hypertension, then there is a very increased likelihood of them going into right heart failure. And if they go into right heart failure, maternal mortality increases to about 50%. There can be associated diastolic dysfunction, especially if the parturients are suffering from hypertension and or on diuretic therapy already. And this can result in pulmonary edema, especially when the baby is delivered. And if there is left atrial enlargement, and left ventricular hypertrophy, it can result in heart failure in these morbidly obese parturients, and this is associated with peripartum cardiomyopathy. So these are some of the associated problems or comorbidities or complications which we have to look for whenever we deal with morbidly obese parturients. Now, why do these cardiovascular problems occur? Yes, there is ectopic lipids, increased inflammation, altered substrate metabolism, and endothelial dysfunction. All these four lead to a cardiac remodeling. And cardiac remodeling means there is decreased systolic and diastolic reserve. So any one of us who tend to deal with these morbidly obese parturient, it becomes mandatory that we do an ECG, do a 2D echocardiography to rule out such dysfunctions and take appropriate action. Along with these cardiovascular problems, we had defined about respiratory issues. The most commonest and the most dangerous ones are obstructive sleep apnea. There is an increased risk of difficult airway, and there can also be obesity-related hypoventilation syndrome, what we define as Pickwickian syndrome. If you look at their blood gases, in obese term parturients, you'll find that the PO2 is already much below what you would normally find in a normal weight term parturient. Now let's talk about obesity related hypoventilation syndrome. There is leptin resistance, and that leads to low hypoxic and hypercapnic drive. But look at the two rectangles on the left side. Sleep apnea and hypoapneas, together with obesity related increased carbon dioxide production, cause increased carbon dioxide loading. On the contrary, impaired lung mechanics and low hypoxic hypercapnic drive decreases carbon dioxide unloading. In simple words, it is increased carbon dioxide production but decreased carbon dioxide elimination. So together it leads to nocturnal hypercarbia. And this is what would be the blood gas picture. They will be having chronic hypoventilation together with hypoxemia. So if they have chronic hypoventilation, the blood gas picture will show hypercarbia, it will show hypoxemia, it may show respiratory acidosis with compensatory metabolic alkalosis, or high bicarb, which is trying to compensate for the increase in CO2. At the same time, because these patients, the parturients have hypoxemia, they will develop polycythemia. So these are the issues which you can readily make out, and one simple investigation which you need to do is an arterial blood gas analysis. Together, like I pointed out, a 2D echo. Now, the second problem, that is obstructive sleep apnea in pregnancy. Obstructive sleep apnea in pregnancy can present in two ways. Either it is first time noticed during pregnancy, then it is called as gestational OSA. But it can be that a patient is already suffering from OSA and now is pregnant. Therefore, chronic OSA gets complicated by pregnancy. So either of the two presentations can exist. Normally, to rule out or to diagnose the presence of OSA, we do the stop bank scoring model, where the questionnaire should have 3 yes to give us an idea that these are high risk for OSAs. But I would actually lower the threshold, and if any of these mothers who are in the category of morbid obesity, if they are suffering from snoring, they must undergo polysomnography, where you have to look for the AHI index. If it is more than 5 per hour, the patient is, or the parturient is positive for OSA. and then you can categorize into mild, moderate, severe pattern of OSA in them. But also remember, if these parturients are having chronic hypertension or hypertensive disorders of pregnancy, there's a strong correlation with OSA in them. And it would be wise that as a part of preoperative preparation, we institute CPAP, BiPAP, or even NIV to optimize their blood gases, their CO2 elimination, and hypoxic drive and hypoxemia, which is existing in them. So, if you are planning a regional block, it would be prudent that you continue with NIV intraoperatively as well. Because during supine position, the diaphragm being pushed up, the delivery being happening, auto transfusion happening, I think all these can contribute to a lot of dysfunction during the intra-op period. So it is wise that the parturient is kept on NIV intraoperatively, even if you have given a spinal to the patient. Secondly, if the OSA grading is moderate to severe and GA has been contemplated, then make sure you perform a wake fiber optic oral intubation. Otherwise, there are chances of losing the airway. The second aspect is, initially NIV was not considered a good choice in full-term parturients. So this is one case we had with severe kyphoscoliosis. She presented to us with 30 weeks of gestation. Her room air saturation was 75%. Yet it's not because of obesity, it's because of severe kyphoscoliosis. So we had to keep her on non-invasive ventilation just to prolong her gestation period. And we kept her on NIV for almost a week. And when the labor was to induced after about 31 weeks, because she went into labor, she went into labor after 1 week, we had to take her up for the lower cesarean sections, lower section cesarean section. She had severe pH in the postoperative period and required 1 week of postoperative ventilation. And we had to start with sildenafil to counteract the PAH which she was suffering from. So this is one case, and it becomes an example that NIV before cesarean sections or delivery does help in a positive outcome in such patients. Apart from 2D echocardiography and arterial blood gas analysis, there is a lot more done in the preoperative assessment. You especially have to look for a difficult airway and a difficult neuraxial block. And it is prudent to use an ultrasound to at least locate which spaces you're going to use. Try to put the patient in a help position to simulate the position which you are going to give the patient, and the patient also knows how she has to cooperate during that time. But if you anticipate a difficult airway, remember the 4 categories which you will have to look for the predictors, especially for difficult supraglottic airway insertion, because that's supposed to be your lifeline. But if the parturient has predictors for difficult SAGA insertion, I think it's wise that you take her up with an awake option. At times, it's good to perform an ultrasound to locate the cricothyroid membrane. But remember, when you mark the cricothyroid membrane there, and when the patient is paralyzed and you start giving face mask ventilation, the marking doesn't correspond anymore to the cricothyroid membrane. It will shift. So these are certain precautions which you need to take. I would rather do something more. If this patient is seen preoperatively, I would explain the patient what she is going to expect from us. We'll probably show her an educational video or give her handouts and discuss the postoperative pain relief regime with her. I would take her to the theater, put her in a sitting position in which I'm going to give her a regional block, ask her to give a posture which I would require when I want to perform the block, so that she is well aware and she is cooperative enough when I bring her for the actual section. She knows how to give the position. Most of the time, mothers are brought into the theater, wheeled into the theater. The attendant tries to bend the neck, flex the hips, without even the mother knowing what is happening to her. It's extremely important that we explain how position is given and how they have to cooperate, how they need to protrude their vertebral column outwards, not bend forwards. So these are certain things which need to be simulated or explained and practiced with the patient pre-op. And also take into consideration, this patient whom you have seen in the morning may present to you in the evening with an emergency LSCS. And you would have no time to do all these maneuvers which you wanted to do at the time of elective LSCS. So whenever you get time, the first opportunity, utilize to prepare yourself and the patient for a regional block or for a difficult airway, what is expected out of them. There is something called as prehabilitation, and most of the ERAS guidelines incorporate this. I take an example of the study which we had published almost 11 years back. We used always a volume oriented incentive spirometer because it makes more sense. This bobbin which you see here, the smaller one, it has to be kept between the two arrows so that we generate mid-inspiratory flow rates. The flow rates which are generated are important for total lung expansion. If this bobbin goes above the upper arrow, the patient or the parturient is taking too high flow rates and it is going to expand only some portions of the lungs which are well aerated already. So they need to bring the bobbin between these two arrows, maintain it there, and the volume would be indicated by the sliding part on the larger barrel here. Whereas balls are concerned, these are flow oriented spirometers. They to me are just toys and do no benefit to the patient. So to cite to you why preoperative spirometry or incentive spirometry, or if the patients are not cooperative, even NIV may help. This is a case study or a prospective blinded study which we did in 2010. These were daycare patients who were coming for lap cholecystectomy. And look at their forced vital capacity. The ones who performed preoperatively for 1 week, they were accustomed to do that post-op as well. Their reserves were built up and they knew how to use the spirometer. Then those who were given the spirometer after surgery, when they were least motivated, they were feeling sick, they were not able to sit up, they were not able to even walk up, and they would most of the time like to lie down. How would you expect them to do incentive spirometry every hour during the time when they are not feeling too well? If we get fever, we hardly get out of the bed because you are not too well to perform such intensive exercises. So it's better to build up the lung volumes, their capacities pre-op, whatever time you get. Let them get acquainted with the devices and let them know how to use them. Now the most difficult part is the part of starting the case. You may have everything prepared, but if you don't get a venous access, you'll be struggling for 1 hour. There are various ways of doing it. The first one is multiple tourniquets. Believe me, it helps. Second is knowing the anatomy and use of ultrasound guided cannulations even for peripheral veins. You always don't need a central access. All you need to know what is the basic anatomy of the veins. So these are the superficial veins. There are two of them which we normally consider. One is cephalic, the other is basilic, and there is a median cubital vein. If you know where they exist, just have to put a probe onto their anatomical site and take a longer cannula and use the vein to cannulate them. There are certain deeper veins like radial and ulnar which combine together to form the brachial vein, but they are actually deep. So you may not be able to puncture them. Try to use the superficial ones. All you need is an ultrasound, and the ultrasound which gives you the larger diameter of the largest vein, choose that. But make sure you distinguish the vein from the artery before cannulating with the use of Doppler. In case general anesthesia is the option, always anticipate and prepare for the worst, which means you must already have one help in the theater who is a person who is more acquainted. Even an ENT surgeon at the time would help. Positioning the patient for general anesthesia, you will have to have a ramped up position with the patient in a slightly Trendelenburg position. And at times we also give some amount of lateral tilt to them. Wedges placed where for morbidly obese patient just get compressed under the weight of the fat. They do not tilt the pelvis. So you will need to give a lateral tilt. At times manual displacement of the uterus would be essential. So make sure that you already do it before you induce, that how much lateral tilt is sufficient for the morbidly obese patient. Second aspect to remember is that it's not only pre-oxygenation when the patient is awake, but it is apneic oxygenation which has to be incorporated so that the safe apnea period is increased and the patient and the parturient doesn't desaturate when you are attempting laryngoscopy. At times you may have to strap the breasts which are coming on your way. Difficult airway cart must have a supraglottic airway device. You can have video laryngoscope, which should be your first choice when you want to perform laryngoscopy, and a bougie, because you will require a bougie along with the video laryngoscope. Have an ultrasound just to locate where the cricothyroid membrane is so that you are comfortable in performing front of the neck axis. Now, when you have given induction, a crash induction or a rapid sequent induction, it is not always mandatory that you need to perform face mask ventilation. In this patient, if you see after induction, the respiratory movements are being transmitted to the reservoir bag. So if there is a transmission of these respiratory movements to the reservoir bag, the airway to me is unobstructed. And there's no point in trying to give positive pressure ventilation during this time. But in case you need to perform positive pressure ventilation with a face mask, please do that preoperatively. That is something which I routinely practice. So this is one of the morbidly obese patient on the table. I have put in the mask, and after putting the mask, I am giving her positive pressure ventilation. If you look at the squeezing of the bag and the chest movements, you will find with each compression, the chest is inflated, and I'm in complete control of her respiration even when the patient is awake. She's completely awake here. So these sort of maneuvers are extremely helpful. You can also do that. You can also do it in a little safer manner. Safer means use the APL valve to adjust the airway pressure limit to 15 centimeters of water. That means when you squeeze the bag, you do not increase the pressures beyond 15 to 20 centimeters when you can fill up or put those gases into the stomach. What are the advantages? How does this awake face mask ventilation help? It's a cue to a better preparation. It helps you to identify whether the face mask fit is appropriate, and if there are any sites of leak where your assistants can just place fingers and actually stop those leaks. Secondly, closing the APL valve to 15 to 20 centimeters, you prevent atelectasis, the absorption atelectasis which can happen when you deliver 100% oxygen. Thirdly, there is adequate oxygenation of the volume which is available as oxygen reserve. So you are trying to recruit the function